Okay, again, welcome back, guys. This is our second public episode here at Washington University in St. Louis. My name is Timothy Yao, and I am joined today by our nepropathologist, Dr. Joseph Gaut, and our renal fellow, Dr. Pranjal Sharma. They will be going through two biopsies similar to the last episode, and we will watch them struggle and work through it. So the first case. 35-year-old Caucasian female who was recently diagnosed with hypertension. She is noted to have hematuria and proteinuria, which prompts the nephrology referral. The creatinine is 1.4, albumin is 4. Urinalysis reveals 1 plus protein, 2 plus blood. The protein to creatinine ratio in the urine is quantified at 0.7 grams per gram. And your secondary workup, ANA double-stranded, HIV, Hep B, and Hep C, are all negative. So, Pranjal, why don't you walk us through a differential given this history?
Sure. I think my first differential would be IgA, given her age, and then subnephrotic range proteinuria usually. And I was going to put lupus as second, but then you have negative ANA and dsDNA, so that rules it out pretty much. I don't have much history about drugs and other things, but DMAs could also lead to this. Or vasculitis, depending on her creatinine is slightly elevated. How rapidly this is developing, we don't know.
Sure.
Could be ANCA positive, negative, or the vasculitis.
Yeah, that'd be unusual at this age group.
But
I guess
it will be unusual.
Joe, I mean, if you were given this history, would you have any other thoughts outside of IgA? I mean, it really is screaming IgA.
It's pretty screaming IgA
Yeah.
for me too, especially with the lab workup that you're giving us here, which is very nice.
Okay, good. So let's see if you have IgA. All right, I'll pass it
All
over
right,
to Joe.
Pranjal. What stain do we have here?
This is a HNE stain.
Very good.
So looking at it grossly, I do see some. The tubules actually look back to back. There's not much of edema. Few tubules are dilated, but most of them actually look kind of okay. There are some debris in a few of the tubules, though. We'll have to look at a higher power to get a better idea of what they are. The few gloms that are there, they look okay. There are parts which may be hypercellular. It's really hard to tell at this point.
Sure, but on here we have a vessel.
And the vessel actually looks a little bit thickened, but not...
Perhaps, but we need to look a little higher to see.
We need a high power to basically evaluate everything.
You're going to get a high power. Let's see.
Okay, so again, HNE stain here on the glom. The tubules surrounding it kind of look okay. Mostly proximal tubule, not much of ATN, except for maybe one down at the 5, which has got flattened epithelium.
Maybe minimal.
Maybe.
It's
Not-
a little
not
bit
much.
flattened, but it's not exactly striking, is it?
Yeah.
And we certainly don't have any coagulative type necrosis in any of these tubules.
Yeah.
All right, so let's move on to the glomerulus here.
The glom, capillary loops look okay. There are a few areas. The mesangium overall doesn't look very expanded, but there are areas where our cells are compact. Yeah, right around there. Might be a little bit hypercellular over there, and then there are a few areas here and there which are a little bit hypercellular, around 5 cells in each of those areas. The capillary loops look okay overall.
So we do have some mesangial hypercellularity
Yeah.
in this particular instance. The capillary loops don't look terribly thickened, unlike our previous case, and they're also nice and open. You did mention TMA, thrombotic microangiopathy, and part of your differential there, although it was pretty low on your
Yeah, it
differential.
was very low.
And in there we would expect to see what?
Some hyaline thrombi, not hyaline, but fractured cast of RBC.
Well, fibrin thrombi.
Fibrin thrombi.
Fibrin thrombi in here in the capillary loops, or perhaps in the proximal arterioles, and with some fragmented red blood cells, like you were mentioning, and some karyorectic debris. We don't see anything like that here. You also mentioned, well, maybe it's an ANCA or some sort of vasculitis.
Yeah, I will see endocapillary proliferation. No.
Or extracapillary proliferation, crescents, right? We'd want to see.
Yeah, and crescents.
We don't see anything going on out here, or segmental necrosis areas in the glomerular tuft. We don't see any necrosis of the glomerular tuft to suggest something like that's going on, but it was pretty low on your list.
Yeah.
On your list too. So why don't we? Do we have any other?
Yes. Here's another glomerulus.
Again, it looks like HNE stain.
Yes, it is.
Okay. That area right there.
Let's just go to the.
Let's go to the money.
Yeah.
What do you think? So first of all, just describe what it is here. Is it use our renal pathology terminology. Is it global or segmental process?
It's segmental.
Okay.
It's segmental, and I don't definitely see any scar or anything, but
it's not a scar.
Right.
So what is this?
And it's just mesangial expansion, maybe.
Well, we're kind of right here at a segmental part of the tuft. We see a dividing nucleus right here, which looks like a mitotic figure. It's difficult to be for sure, but that's what that looks like down here. And it's this kind of red, granular-looking material.
Yeah. I was wondering if... I don't know if this would be like blood, or it could be...
You're on the right
PS,
track.
PS.
So this is a focal necrosis. This is actually
necrosis.
focal necrotizing lesion in this particular glomerulus. It's kind of granular, eosinophilic, brightly eosinophilic color on the H&E. It should be bright red on trichrome, if we have a trichrome picture of this, but regardless, this is a focal necrotizing lesion. Okay.
And that redness you would describe as fibrin, right, Jane? Or Joe?
Jane, yes, no.
Sorry, I
that's right.
thought you were my daughter for a second. Yeah, Joe.
Exactly. This looks very much like fibrinoid necrosis.
Okay.
That's what that is.
I'll give you another image here.
So this is PAS stain. Again, the capillary loops don't look... They're, again, open in this picture. There's... I don't know how well I can appreciate the hypercellularity.
No, exactly. You don't see much here. Here's a nice area of mesangium, maybe 2 nuclei there, maybe 2 or 3
maybe
here.
2 or 3 there. The central
This is
area,
down at the pole.
Yeah, so central area again shows maybe PS positive, so fibrinoid necrosis kind of picture. Maybe mesangial expansion a little bit over.
Well, we're down by the vascular pole here, so it always has a little bit more mesangium matrix in that particular area. So don't overinterpret this as a segmental scar. But yes, the capillary loops are open. Fibrinoid necrosis on the PAS will be somewhat of a pale color, kind of a pale pink, not this bright pink color that we see here that typically stains collagen. We don't see much of that really here.
Okay, and that's the last light image. So kind of what we're taking away is mesangial hypercellularity was pretty obvious in that first one. We had that funny area of focal necrotizing fibrinoid necrosis, and so we'll see kind of what we have on immunofluorescence. So this is...
It's positive for IgA.
Okay, great.
It's in the mesangium and surrounding the capillary loops, and it's granular, so yeah, it's IgA, just and mostly in mesangium. And
okay,
absolutely.
All right, and this is IgG, which is
negative.
Okay.
Now that's important. You see that focal necrotizing lesion. Now granted, anti-GBM disease was not really high on the list. Yeah. We didn't really think that. And typically you'd see diffuse involvement with crescents and things like that in those particular cases. But we did see a focal necrotizing lesion, which sounds a bit more like a vasculitic process. Perhaps it's all related to the IgA. Perhaps there's something else going on that's coexistent with the IgA. But that's an important stain to at least review.
Okay.
So this is EM, and so...
let's orient ourselves first.
So this is in the capillary loop. You can see the fenestrae very nicely.
Right here.
And the podocyte foot processes are also intact.
Very good.
They're normal.
Out here.
So yeah, and then urinary process. So now the electron dense deposits are usually in the mesangium that you can see right where you are pointing. No deposits in the GBM. So they are mostly mesangial deposits, electron dense.
Okay.
Very good. So there's mesangial electron dense deposits here, and no subepithelial, subendothelial, intramembranous deposits. And the foot processes look intact, and the glomerular basement membranes look to be a relatively normal thickness.
Okay, here's a closer up view of, I think, a mesangial area.
Okay.
Right. Let's reorient ourselves here again. It's somewhat tricky, but what do you see
difficult.
here?
So that's again the fenestrate endothelium. So,
so this is
then the capillary loop that we
out
have,
here.
And that's the urinary space with the foot processes.
Very good.
And so this is your mesangial area, I guess.
Yep.
Yeah.
Very good. And what am I outlining here?
Oh yeah, that's the electron dense deposit.
Electron dense deposits. Very good. Just a higher power view illustrating that again. So we have
IgA.
So I guess we can sum this up.
Yeah, it's just basically it's mesangial hypercellularity and a focal area of necrosis, which can be present in IgA, I guess, and everything else was negative, so IgA nephropathy.
Right.
I would certainly want to know the result of an ANCA, though.
Sure.
Because it could coexist with IgA.
Right.
And patients
Although typically, an ANCA would be possibly immune on EM too, right? I mean, do you ever see electron
Well, you can have
deposits?
IgA
coexisting.
plus
what you're
ANCA.
saying.
It is entirely possible.
Sure,
So you could have IgA in the background of an ANCA-mediated glomerulonephritis. So I would still want to know the results of that testing. At least I would recommend we obtain that, even though it is unusual in this age group.
Right. Okay. So you did great. That was a little bit of a harder case because I threw in that focal necrotizing lesion because it isn't your typical IgA nephropathy. But just to quickly go over IgA, it is the most common idiopathic glomerular disease. It manifests typically with hematuria, subnephrotic range proteinuria, which this patient had only 0.7 grams. So it can present with nephrotic syndrome, but again, it's usually a lower level. It's one of these diseases that does have a racial predilection. It is extremely rare in patients of African descent. So most large cohorts looking at IgA nephropathy, only about 5 or so % of the patients are African or African American. And it has a variable prognosis. Primary IgA can progress to ESRD, but it typically takes a very long time. The studies have looked at them over about 10 to 20 years, and in that time course, about 20 to 30% of patients can progress. So histologically, IgA can be a lot of things, and I want to emphasize some of the things that we saw in this case. So on light microscopy, I think we pretty clearly saw mesangial hypercellularity in that first image. You can have endocapillary proliferation, which wasn't too evident in this case. You can have segmental glomerulosclerosis. You can have crescents or fibrinoid necrosis, which was that focal necrotizing lesion. You can sometimes see GBM duplication, mesangial interposition, almost like an MPGN picture. And then varying degrees of tubular atrophy and fibrosis, which really is one of the most important prognostic findings in IgA nephropathy at the time of biopsy. The IF always shows IgA dominant or codominant staining in the glomerulus. And the EM can show electron-dense deposits anywhere, but typically mesangium, although sometimes you can see them in the subendothelium or even in membranous spaces. Okay, that was great. So I'm going to give you another case here. Similar presentation. So we're still in the hematuria tract here. So this is a 23-year-old female who comes in for microscopic hematuria. She already had a urologic workup, including a cysto and a CT scan, and negative for stones or anything like that. Her creatinine is normal at 0.7, albumin is 3.9. Her UA shows trace protein, 2 plus blood, 12 RBCs, and our urine protein creatinine ratio is quantified at 300 milligrams per gram. So differential here, Pranjal?
Basically a young female with microscopic hematuria, very minimal proteinuria, so without any other significant history given, and normal creatinine, I would lean towards Alport's or thin basement membrane disease.
Okay.
Those two would be my main differentials, especially in a young patient like that. And then again, IgA can present in a similar fashion, but I would keep that as lower in my differential.
Yeah, and I think that's exactly right. I mean, if your thin basement membrane Alports typically you would expect to see some others, systemic issues, hearing, vision, and IgA can present this way, although it would hopefully be nothing terrible on the biopsy. It would be early on in the disease. So let's look at the tissue.
It's a trichrome stain. I see that right down here it's more of the cortex. We are going towards the medulla as we go up, probably.
Possibly. It's very hard to say. We have pretty much a bunch of cortex here. So we picked up something else down here, so we don't confuse the whole audience. What do you think that is? Parasite?
Muscle.
It's a muscle. Very good. It's a little bit of skeletal muscle down here on the trichrome.
At least it's not liver, right?
At least we didn't hit the liver or some bowel down there. So excellent. So we have some cortex. So is there much in the way of interstitial fibrosis?
No, there is essentially very minimal, if there is any. I don't see much interstitial fibrosis at all. The tubules look back to back. There's not even much edema. So I think that
now, were you expecting to see a lot of edema with the normal creatinine? So so not much edema, not much fibrosis. Really looks pretty unremarkable. And how about global glomerulosclerosis? We have quite a few glomeruli here.
Yeah, none of them are actually sclerosed.
None of them in this field.
No glomeruli sclerosed.
Very good.
Okay. This is H&E stain. The interstitium actually looks okay. It doesn't look very hypercellular or anything. And the tubules look fairly okay. The proximal tubules, mostly they look okay. There's not much of dilatation or atrophy or necrosis that I can see. So they're okay. Then coming to the glom. Okay, so this glom, There appears to be some. Well, the capillary loops look open for most part. There appears to be some mesangial expansion. I don't see much hypercellularity for most regions, however. This actually looks very full, but otherwise.
Well, it's nice. The glomerulus is supposed to fill out Bowman's space, so you're right
completely.
up against Bowman's capsule here. So
Yeah.
this is normal
Normal.
for it to do that. And we really, like you said, there isn't any real significant hypercellularity, whether in either endocapillary, extracapillary out here in Bowman's space, or in mesangial
Or in
regions.
mesangial.
It looks pretty unremarkable. It'd be nice to see a little higher power picture where we can really get a better appreciation for that. But for the most part, these look pretty unremarkable, wouldn't you say?
Yep, normal.
Great.
Okay. That's PAS.
Very good.
Stain. Again, looking at the Bowman's capsule, it looks normal, but the capillary loops, they're pretty thin.
Well,
I'm
it's
not
very
really-
hard to appreciate
Yeah.
thinness. Even our appreciation of thickness is somewhat
Thickness.
subjective on these stains. The thinness is also very difficult to appreciate just on light microscopy. We really want to look at that by EM.
They're not staining as dark as the tubular basement membranes, though, overall.
Well, perhaps, but I would not want to hang
Not-
my hat on that
yeah.
one.
Otherwise, yeah, mesangium looks okay. There's no hypercellularity. The capillary loops look open. There is no proliferation going on there. So overall, it looks kind of normal.
Okay.
Very
Great.
good.
And a silver before we move on.
So again, there's not much of silver positive deposits I can see, or negative deposits.
Be careful with your terminology
there-
because
there-
there's no such thing as a silver positive
yeah.
deposit, right?
Right, so
Yeah.
silver just stains
Yeah,
the collagen.
it stains
here.
the collagen. So they are, it looks normal. It's lining the capillary loops and.
Right, it looks pretty unremarkable.
Yeah.
You can't see much in the way of expanded mesangium. Here's a mesangial region here that looks relatively unremarkable. There's no increased collagen deposition in here. You don't see any spikes out here in the periphery. Granted, you weren't even considering membranous, but that's something we always tend to look for in the silver. And it looks like a pretty unremarkable glomerulus, just like what we were seeing earlier.
Okay. So here IgA
Negative.
completely negative, and here's EM.
All right, moving to the EM. So let's orient ourselves first.
So that's the end of the fenestrated basement membrane.
Okay, what are these things
And
here?
these are RBCs.
Red blood cells, very good. And
That's
here's their
that's the
fenestrae.
fenestrated
All right,
endothelium.
so
and
this
that's
space?
urinary space.
Very good.
The podocyte and the foot processes actually look intact
Yes.
for most part. So they look intact, nothing
Mhm.
significant over there.
How about
the base-
electron-dense
The
deposits?
deposits, we're trying to look at in the basement area in the GBM.
Do you see any?
I don't think there's.
Are you expecting to see any?
No.
Well, you did have a totally negative IF,
No.
so it would be pretty unusual to have much in
Unusual.
the way of deposits here.
deposits.
So no deposits.
No
So
deposits.
now let's get to the glomerular basement membrane. So your
It
principal
certainly
diagnosis,
appears
right?
thin basement
You're
membrane
thinking of
disease.
thin membrane. So how do we define it as as thin or thick or normal? So how old?
As-
She's 25, right?
25.
So what's a normal
It's,
GBM thickness for a 25 adult woman?
around 380 to 600, I guess.
Well, it's 600 is a little bit on the thick side. So let's go down, 350 plus or minus 50 for average adults, and women are a little bit less than that, probably 320. I don't remember exactly, but somewhere in that range.
350.
So I'm sure we have some measurements on this, but just looking at this and comparing it to the ones we've seen
We have
previously,
seen-
this
yeah.
is clearly too
Okay.
thin, right? This is nowhere near looking like a normal thickness of a glomerular basement membrane.
Yep.
And with this clinical history and everything else looking the way it does, it certainly fits for thin basement membrane disease.
Okay. And I unfortunately don't have a legend to compare to, but again,
That's
high-
okay.
high power.
We can appreciate this just looking at high power and looking at the EM and how thin this particular glomerular basement membrane is. Now, when you measure this, you measure from the base of the podocyte foot process here, right here, down to the endothelial fenestration right here. So, or the endothelial cytoplasm, and you can see the thickness of the glomerular basement membrane. But in this case, it's quite obvious just by looking at it that
It's
we
thin.
don't even need to do that. This is a thin basement membrane disease.
Okay. And there were stains for alpha-1, alpha-3, and alpha-5 chains of type 4 collagen, which stain normal. Now, do we routinely do this, Joe?
We do not routinely do it when there is suspicion. So in this case, when you have thin basement membrane disease, one of the diagnoses, we're a female, right? So it's not going to be your typical X-linked Alport's autosomal Alport disease. Now, she could be a heterozygote, a carrier of Alports and of different variants, which can present initially with thin basement membrane disease. However, I mean, this is somewhat of a spectrum, and so what we might see here is some mosaic staining for these different collagen alpha chains. However, they are completely preserved. If there really is a strong family history or clinical suspicion that this family does have hereditary Alports, then perhaps genetic testing would be warranted. But this meets all the criteria for thin basement membrane disease based on what we have here.
And I would say that from experience, if you have normal staining of these alpha chains of type 4 collagen, certainly doesn't exclude Alports.
Right.
So there is specific serum testing, genetic testing, which can be done for that. So the diagnosis pretty clearly here is thin basement membrane nephropathy, and you did a great job interpreting that biopsy. So this is actually quite common. It affects 1% of the population, oftentimes familial and classically autosomal dominant pattern. The typical presentation is very similar to what this patient had, which is a symptomatic microscopic hematuria. Proteinuria is usually very low level, and renal function is preserved. It can be caused by mutations of collagen type 4, alpha-3, or alpha-4 chains, and this can oftentimes be confused sometimes with Alport syndrome, which can also lead to thin basement membranes if you catch it very early in the disease. This thin basement membrane nephropathy typically does not progress to ESRD, and it does not have the visual and hearing deficits that are typically seen in Alports. We went through this, which is a nice reminder that males, females, about 300 to 350 plus or minus 50 is a normal thickness for adults. In children, obviously, it's very different. I honestly don't even know the numbers, but it gets thicker as they get older. And so to make the diagnosis of thin basement membrane requires a basement membrane thickness of less than 250 nanometers diffusely. In Alport, sometimes you can see these alternating thin and thick areas, or you can see things like lamellations, which are more suggestive of Alport's disease. And this data on the males, females, and the thickness is taken from an article which I cite down here. So again, thank you for tuning in for our second web episode. Again, you can email me here with any questions. Please feel free to ask any questions or give us suggestions on how we can improve this webcast. Follow our YouTube channel at WashU Nephrology. Follow me on Twitter here. I want to thank again Dr. Simbaluk, the nephropathologist up at Rush, who provided these images, and thank our sponsors, the Renal Fellow Network, AJKD Blog, Nephron Power, and NephJC for endorsing and sponsoring us, and we will see you guys next time. Thanks.